Good evening, everyone. And I would like to thank the PKD Foundation for organizing this very important session. We would be talking about introduction to PKD, and I would be co-presenting this with Dr. Winkelhofer.
Yeah, hi, I'm Franz Winkelhofer. I'm one of the nephrologists at KU Med Center, and I started the PKD clinic at the University of Kansas.
Thank you. So I'm Dr. Ashima Gulati, and I'm one of the pediatric nephrologists at Children's National Hospital in Washington, D.C. We would start the presentation by introducing the two major forms of PKD, both ADPKD and ARPKD. And then Dr. Winkelhofer would talk about ADPKD in further detail before I then talk about some specific PKD issues in children and young adults, and then we will be happy to take any questions. Polycystic kidney disease, or PKD, is majorly of two forms, and many of us have heard this ADPKD and ARPKD. ADPKD is the most common genetic cause of kidney disease worldwide. It's the autosomal dominant form. And when I say most common, I mean an incidence of 1 in 400 to 1 in 1,000 live births. So that makes ADPKD probably like about 12 million people affected worldwide. In the center, we see these large cystic kidneys. There is formation of these fluid-filled cysts, which replace the healthy kidney parenchyma. And on the left, you can see a cartoon of the kidney showing that cysts and ADPKD can arise from anywhere in the nephron, which is like the functional unit of the kidney. On the right-hand side, we see the two most common genes that cause ADPKD, namely PKD1, which is responsible for majority of portion of people with ADPKD, and then 15% of the cases will be due to PKD2. And then there is this a subset of patients who are NMD, which stands for no mutation detected in either PKD1 or PKD2. And so these people, although they have PKD, would not either have a PKD1 or a PKD2 mutation that is found by genetic testing. And there are additional complexities to say that why we would not be able to find a mutation in these patients. The second form, which is autosomal recessive, or ARPKD, is much less common as compared to ADPKD. It's seen in 1 in 25% live births. The cartoon that I put on the left side is just to give an idea that the cyst formation in ARPKD is probably slightly different in how the cysts arise in the kidney in ARPKD rather than ADPKD. It still gives it still manifests as large kidneys, but typically not those big cysts that you see in ADPKD as you see above. The one gene that is responsible for about 99% of cases is PKHD1, and not all cases of ARPKD you would easily detect PKHD1, and then again there are technical complexities to detection of these genes, but you would be able to detect this PKHD1 mutation in about 80 to 85% of cases of ARPKD. With that background, I would like to again clarify that ADPKD is the dominant form of PKD. When we say the dominant form, it means that you need only one unhealthy allele for this disease to manifest, that you see on the left side of the slide. So with every pregnancy, there is 50% chance that the baby can inherit the condition from an affected parent. On the other hand, the autosomal recessive form of PKD would require two unhealthy alleles, so both copies of the gene to be unhealthy for it to manifest in the child. So with every pregnancy, there would be a 25% chance of getting ARPKD. Whether a family history of polycystic kidney disease is present or not in the family, it is very informative both for making a diagnosis and also for an individual to know what to expect. But if there is no family history or if the family history is absent, it does not rule out either ADPKD or ARPKD totally. I would like to just point out some differences and overlap between these two forms of PKD, that is ADPKD and ARPKD. Mostly, there is a different inheritance pattern that we just saw. The genes and the proteins responsible for ADPKD and ARPKD are different. What is more interesting is that the way the cysts form in both conditions is highly complex, but there are also some maybe overlapping mechanisms which are yet being studied. But as a result of those that knowledge, similar therapies are being tried for ADPKD and ARPKD. But again, the mechanisms are very complex and still being investigated. ADPKD mostly comes to clinical attention in adults, but it can present very early, even in the neonatal period. ARPKD mostly comes to clinical attention in children, but there are rare cases that can present in later adolescence or adulthood. Non-kidney involvement, which can happen in the form of cysts or blood vessel abnormalities such as aneurysms, are more common in ADPKD. Whereas in ARPKD, you can have severe involvement of the liver in terms of liver fibrosis. There can be lung involvement, especially in neonates. So those are some of the differences and overlapping features of ADPKD and ARPKD. With this, I would like to hand over to Dr. Winkelhover for the introduction to PKD.
Okay, thank you. Yeah, so this is, I'm trying to move. I'm having trouble moving the slide. Oh, here, well, now it's just a lag. Here we go. Let me go back a bit. Okay. So in the time that we have, this is just going to be a pretty high level introduction to autosomal dominant polycystic kidney disease, and we'll try and go over some of the pathogenesis, which we'll do quickly because Dr. Galati kind of outlined some of the same things. Then the disease manifestations, how we diagnose, and then ways that we can get a sense of prognosis and progression of the disease, and then some treatment options. So yeah, this is very common and is the most common potentially fatal hereditary disorder. It accounts for about 5 to 7% of all end-stage kidney disease in North America. And as mentioned before too, with autosomal dominant inheritance, that means that there's a 50% chance of passing the disease to any potential offspring, whether they get the affected gene or the normal gene. An affected parent would have a mutated gene and a normal gene. So there are two different gene mutations which essentially cause the same disease. And we call them PKD1 and PKD2. Each of these two mutations form a different protein. One is called polycystin 1 and polycystin 2. The PKD1 mutation is more common, as Dr. Galati mentioned. It tends to be a little bit more severe with earlier onset end-stage kidney disease, typically in patients are around 50 years of age on average. The PKD2 mutation tends to be a little less severe on total, and end-stage kidney disease closer to age 70 on average. This idea was kind of held for years and years until we've known more about genetic mutations and the different mutations with PKD. And you may have read about truncating and non-truncating mutations. A truncating mutation means that the mutation may cut off a big portion of the gene. A non-truncating mutation is something where maybe there's some misspelling in the gene, and the more of the gene that is cut off, the more severe the disease can be. So that's why there's kind of some gray area between how severe PKD1 and PKD2 can be. But again, this for the most part, we don't have access to the genetic information in most patients at this point. This is just a cartoon showing that polycystin 1 and polycystin 2 interact, and they form a protein that makes a calcium channel. And I guess it just, I think it's instructive to know that the reason that these two different genes can cause the same disease is that they come together to form a complex. And if you have a problem with polycystin 1 or polycystin 2, this calcium channel isn't activated, and that kind of explains why both these mutations give kind of a similar disease pattern. This is just a very graphic picture showing how big some of the kidneys can get as patients approach end-stage kidney disease with PKD. So certainly the most significant clinical manifestation of polycystic kidney disease is kidney failure, which basically means requiring dialysis or transplantation. It's rare in patients before the age of 40, but 50 to 75% of affected patients may reach end-stage kidney disease by the age of 70. Risk factors for more aggressive progression are patients that have enlarged kidneys, and TKV means total kidney volume. I'll mention a bit more about that in a bit. Male patients tend to have faster progression. As mentioned before, PKD1 mutation tends to progress faster. And then other risk factors are patients that have high blood pressure, especially uncontrolled, and then also patients with gross hematuria or visible blood in the urine, just multiple episodes over time. Probably the most common and especially early manifestation is high blood pressure. 2/3 of patients are diagnosed with hypertension by the age of 30, and then by the time patients reach end-stage kidney disease, virtually all of that population has hypertension. And then worse hypertension, or the presence of hypertension, is associated with bigger kidneys and faster kidney growth rates. Kidney infections are not necessarily more common, but somewhat more. And the real concern that we have with a kidney infection is that it may involve an infection in the cysts. Many of you listening may have had some sort of a bladder infection, which can be relatively easy to treat because it's easy to get antibiotic into the urine. The problem with cyst infections is that if you have bacteria in those cysts, it's very hard to get antibiotic into the cysts, and certain antibiotics are more able to penetrate into the cysts, and many times they can require longer treatment. Patients with PKD and kidney infections should probably consult their nephrologist, because this is one area that's not commonly understood in the general medicine and family medicine population, that these infections are harder to eradicate. Blood in the urine is also very common. It can be visible. Patients that rupture a cyst, where a cyst grows into a blood vessel and bleeding occurs into the cyst, if it communicates with with the urinary collecting system, you can have blood in the urine. Many patients will have dipstick blood in the urine, so it's not necessarily visible, but it's able to be picked up on lab testing. That's just in patients with PKD is probably something that happens at least 50% of the time. Certain activities can predispose you to these episodes. So strenuous activities or trauma to the abdomen can also cause it. Another area that can cause blood in the urine or also just pain or kidney stones, and the incidence of kidney stones is a bit increased in patients with polycystic kidney disease. One of the more difficult areas to manage are patients that have flank or abdominal pain from the kidneys. Patients can have episodes of pain, or unfortunately, a number of patients will have constant pain, which can be very difficult to manage. The thought is that it's caused by stretching of the cysts or pressure. It can be also due to cyst rupture or infection or kidney stones. It tends to be more common in patients that have large kidneys, but it's also it can also be seen in patients that have much less severe cystic involvement. Again, it's difficult to identify the cause. If we do have a sense that it's caused by infection, for example, we try and manage the underlying cause. Sometimes it's appropriate to get imaging to see if we can identify perhaps cyst hemorrhage or areas of bleeding in the kidney or areas of inflammation which might be from infection. Sometimes we can identify a particularly large cyst that may be pushing on surrounding tissue. Sometimes those types of cysts can be aspirated, or there are potential surgical interventions which can be pursued. Now, non-kidney manifestations, I'll just go over a few. The one that's probably the most potentially devastating are intracranial aneurysms. An aneurysm is a bulging blood vessel that's due to a weakening of the wall of the vessel. This type of weakening can rupture and cause severe bleeding, so that can manifest as a stroke and can cause swelling in the brain and potentially death. 3 to 7% of patients may have aneurysms, depending on different series. The risk increases if there's a positive family history. So that may be more than, if there's a family member that's had an aneurysm, that risk can double or triple. Screening recommendations to try and identify patients at risk are to do an MRA, which is a magnetic resonance angiogram, which is used to look at the vessels. And the patient population in which we try to focus on are patients that have a positive family history, have some new presentation with unusual headaches, or patients that have high risk occupations. And one example of that would be potentially pilots that who could become incapacitated and not just affect themselves but others. Probably the most common non-kidney manifestation of PKD are liver cysts. So a majority of patients will have liver cysts noted by the age of 30. Women tend to have more liver cysts and can have larger cystic involvement, cystic enlargement of the liver. The cysts respond to estrogen. So patients that have had multiple pregnancies or have been on oral contraceptives or some sort of hormone replacement statistically may have more liver cysts. the majority of the liver cysts are asymptomatic, but in patients that have a lot of cystic involvement, it can definitely contribute to the abdominal fullness and distension that patients have. Liver failure, though, as a result of the liver cysts is very rare, but there are circumstances where patients have required liver transplant as well. But again, that's extremely rare. Another just couple, there are heart valve abnormalities. Probably the most common is something called mitral valve prolapse, which is a fairly benign abnormality. It can manifest in some heart rhythm issues and palpitations, rapid heart rate, but generally patients don't have symptoms and don't require treatment. There are times that some of these valve abnormalities can become an issue in later adulthood, but again, that's not very common. Hernias, however, are fairly common. Almost 50% of polycystic patients may have some type of hernia, such as what's called an inguinal hernia, which is down in the groin, or a belly button hernia. And then also, it's more common to have incisional hernias, so patients that have had some other abdominal surgery, like a gallbladder surgery, sometimes that surgical repair can open up and you can have a hernia at that point. So that's just another associated condition that is somewhat common. So diagnosis and screening, it's typically diagnosed by imaging. The most common way we do it is with an ultrasound. That's non-invasive. It doesn't involve radiation or contrast, and it's able to show cysts on the kidneys and the liver as well. It's especially useful for patients that have a family history, because if you're expecting to see cysts and then you have liver and or kidney and kidney cysts, then that essentially makes the diagnosis. Patients that don't have a family history that are found to have cysts often benefit from better imaging, like an MRI or a CT scan, to show better anatomy, show the cystic pattern a bit better, to see whether it's consistent with polycystic kidney disease or something else. Genetic testing is rarely needed, and historically we haven't used it very much at all, but it's becoming more commercially available and commercially affordable. So I think that the idea of doing genetic testing that's certainly going to be more prevalent and changing in the future, I think. And here we go. We use a blood test to check kidney function, which is the serum creatinine, or the GFR, which is measured from the creatinine. And unfortunately, those aren't good indicators of kidney disease or cyst involvement in patients that are relatively younger. For patients with early stage disease and normal kidney function, correlating the cyst burden versus the age is a better way to estimate prognosis. Once patients do develop progressive CKD, then the use of the creatinine or the GFR is very helpful. And this is just a cartoon showing that the kidney function, which is demonstrated by the curve here, with the renal function, remains relatively normal until the kidneys are very large and cystic. So patients may have pretty significant cystic involvement and have normal kidney function, but they may have very few cysts and normal kidney function as well. So what's relatively new is measuring total kidney volume, and then using something called a Razabal classification, which was diagnosed was developed by the Mayo Clinic, using a single MRI or CT scan. Measurements are taken from that image to come up with a total kidney volume, and then that kidney volume is adjusted for the age of the or the height of the patient, and then plotted against age to kind of stratify risk on a to E category. This shows, this top graph shows the height adjusted total kidney volume on the y-axis and then the age. And then so patients, based on their volume and their age, they end up plotted between class A through E. Patients that are class A have relatively smaller kidneys for a given age. The patients that are class E have very large kidneys at a younger age, and the bigger the kidneys are for age, that implies more rapid progression and more significant risk for progression of chronic kidney disease. This green line are patients that have A, that are in class A, versus the red line that are in E. It shows kind of the rate of decline of kidney function over many years. Class A patients may never end up on dialysis or needing a transplant, whereas patients that are in class C, D, and E are considered relatively high risk. And the majority of those are at risk to need renal replacement at some point. So areas of treatment to focus on: high blood pressure, some dietary modifications, tolvaptan, which is the only drug that's been approved to treat polycystic kidney disease, and then I'll mention just a bit about transplant and dialysis. So high blood pressure control is important because it definitely can affect the progression of chronic kidney disease and the progression to renal failure, but it also affects other cardiovascular risk like heart disease and vascular disease. Besides renal failure, cardiovascular disease, those two they make up the biggest amount of morbidity and mortality in patients with PKD. There was an NIH trial looking at blood pressure control called HALT PKD, which suggested some additional benefit in younger patients with more preserved renal function to try and be more aggressive with blood pressure control. Typical targets may be 130 over 80, but the HALT trial suggested that younger patients might benefit from control, perhaps 20 millimeters of mercury, even lower than that. And then the class of drug that we like to use as a first-line agent are either angiotensin converting enzyme inhibitors, which are known as ACE inhibitors, or angiotensin receptor blockers, commonly called ARBs. So we try and use those as early line agents, and then many times we require additions to that as well. So dietary modifications are a big area of interest for many patients, and unfortunately, it's the science and studies of this area is a bit lacking and delayed. But we do know that increased sodium intake in the diet has been linked to faster progression of kidney disease, and it makes blood pressure harder to control. The recommendation is a 2,000 milligram sodium restriction, which that's, if you're looking at a cardiac type diet, a 2-gram sodium restriction is pretty typical for that as well. We know that overweight and obese individuals have more rapid progression of kidney disease, so the recommendation is to try and maintain a body mass index less than 25%, and try and employ a weight loss diet as needed to try and get below that target. Protein restriction hasn't been shown to slow PKD progression at this point, so there's not a recommendation to use a low protein diet, but the recommendations for a sort of a regular healthy diet are between 0.8 and 1 gram per kilo of body weight per day. And so the typical recommendation is trying to keep protein intake towards the low end of that range, so 0.8 grams per kilo of body weight. The suggestion that substituting plant protein for animal protein may be helpful has been discussed as well. There's concern that you have more acid residues from animal protein, which may cause more kidney disease progression. This is an area that's been looked at in experimental models, but we still need more study in humans. And then there's another area that's received significant interest, which are ketogenic diets, and there's promising data from rodent PKD models, but we just don't have human data to support trying something like this, although there are studies underway now, so hopefully that's something that we'll have more information on in the future. So tolvaptan is the only FDA-approved treatment of polycystic kidney disease. It was approved in 2018. It's a vasopressin receptor antagonist. Vasopressin, or antidiuretic hormone, has been shown to drive cyst growth. There are many factors, but this is one area that, or one target that we have that we can use to slow kidney growth. It's, in addition to slowing the growth of kidneys, it also can slow kidney function decline, and it also may reduce pain in some patients. Patient selection for this drug usually centers around those that are thought to be at high risk of progression. Many insurance companies focus on the erazobal class, and patients that are C, D, and E are generally approved for treatment for the drug. The primary side effects of the drug are increased urination, urination at nighttime, and thirst. It blocks the binding of this antidiuretic hormone in the kidney. That hormone helps you to concentrate your urine, which is generally beneficial, but when it binds in kidneys with polycystic kidney disease patients, it also helps to drive cyst growth. So this drug covers up the receptor in the kidney so that the antidiuretic hormone can't bind, which has been shown to slow kidney growth and progression of CKD. But in doing so, it blocks the kidney's ability to concentrate the urine, and that's where the increased urination and thirst come from. A rare cause is severe liver toxicity with this drug, and because of that, the FDA has mandated that liver function testing has to be done monthly at the beginning of therapy, and then quarterly for patients that have been on the drug for a period of time. The liver injury that I've seen in patients taking it has been fairly rare and seems to resolve pretty well with withdrawal of the drug. And then kidney failure in patients that reach end-stage kidney disease. Generally speaking, transplantation is the best option. It affords the best length of life and quality of life, assuming that patients can qualify to get on the transplant list. With respect to dialysis, polycystic patients typically can do either hemodialysis or peritoneal dialysis. Some providers lean towards hemodialysis for polycystic patients because of the enlarged liver and possibly a kidney and possibly liver in those patients. But my experience is that at least as a beginning therapy, most patients can do peritoneal dialysis as well. And then just the last point I'd make is that polycystic kidney patient on survival or patient survival on dialysis or with transplant tends to be as good or better than patients with other forms of chronic kidney disease. It's nice that polycystic patients tend to have relative preservation of their other organs besides the kidneys, and that I think is one of the reasons that they do well with the different forms of renal replacement. And I'll turn it back to Dr. Galati.
All right. Thank you, Dr. Winkelhofer, for that very nice and comprehensive overview of the issues with ADPKD. So I'm a pediatric nephrologist, so I would like to talk about some of the specific issues of polycystic kidney disease in children and young adults. And when I say young adults, usually pediatric centers would care for children or adults going into like 21 to 22 years of age as we prepare them to transition to adult nephrology. So I will talk about some important questions that we think about when we see polycystic kidney disease in children and these young adults. When we see a polycystic kidney disease in, say, a very early age, from perinatal to infant to early childhood, we realize that polycystic kidney disease can present at any age, and we need to think about, is it ARPKD or is it ADPKD or another form of cystic kidney disease? Traditionally, ADPKD was equated to mostly the adult form of PKD, and ARPKD was more equated to the pediatric or the early childhood form of PKD. But we now know that there is a significant overlap, and both forms of these polycystic kidney disease can present at any age. And so whenever we see this in the context of a child or a young adult, we always think, is this ADPKD or ARPKD, or is it some other form of cystic kidney disease which is not AD or ARPKD? So again, going to the same thought, saying that ADPKD, although mostly comes to clinical attention in adulthood, it can present very early, and it can be a very severe form of ADPKD, which can actually present in the fetal to neonatal or early childhood period. And sometimes ADPKD can therefore mimic ARPKD when it presents really early in the fetus or at birth. Similarly, ARPKD, which is a severe form of PKD, which usually comes to clinical attention in neonates to infant period, can also, in some rare cases, present very late during teenage years as a very mild disease. So we always have to be mindful of that age spectrum when one is making a diagnosis of PKD. This is a very common scenario that we encounter as a pediatric nephrologist. We have patients presenting with a fetal ultrasound, and that fetal ultrasound done during pregnancy shows bilateral, large, echogenic or cystic kidneys. And then the question comes again, is this ARPKD or is this a very severe form of ADPKD? And this is a time when, if there is a family history, it helps, it gives extra information. But again, if there is no family history available or if family history is absent, we still need to consider both of those conditions when we think about what this could be. A very important point to note here is that what is the amniotic fluid or the amniotic fluid volume at that time during pregnancy, and that can give an indication as to how severe this PKD is and what would the implications be immediately after birth. when we have a baby who's born with ARPKD or the autosomal recessive form of PKD, what to expect right at birth? These babies are born with very large kidneys. You can see in the center, there is a baby with a big belly, huge kidneys, perhaps giving rise to this big belly. Early on, the problems because of the big kidneys and ARPKD, there can be a preterm birth. Typically, these babies can be born at 34 to 36 weeks of age. In very severe cases, there can be low amniotic fluid, and there can be lung problems because of problems with lung maturity and a mortality of up to 20 to 30%. Because of these large kidneys and ARPKD, there can be problems with high blood pressure. Low sodium levels can be a problem at birth in these babies, and then there can be feeding issues and growth issues. And very importantly, of note, liver fibrosis can be an important component of ARPKD, which can give rise to problems such as portal hypertension. It is important to note that although 20 to 30% of these children, these neonates who are born with ARPKD can have a very catastrophic course and can die, but 70 to 80%, which is a very huge proportion, will actually survive into adulthood. And half of these survivors can develop end-stage kidney disease. So there is a significant proportion of ARPKD patients who will survive into adulthood. And ARPKD to a pediatric nephrologist is, I think, one of the most clinically challenging condition. It really needs a multidisciplinary care team. It needs an expert kidney team. It needs discussions on need for dialysis, need for transplant of the kidney, and in some cases, both kidney and or liver transplant. And then there are other issues related to the growth and behavioral neurocognitive issues which need to be taken care of. There can be liver fibrosis, as we said, so a hepatology team is also something that would be very crucial as part of this multidisciplinary care team. Early removal of kidneys, just because those kidneys are very large, it does not mean that those kidneys need to come out very early. So this is not evidence supported and is not advocated in all cases. So after that, those issues with ARPKD, I would like to touch upon some unique ADPKD issues pertaining to children and young adults. ADPKD, as we just heard from Dr. Winkelhofer's talk, it comes to clinical attention probably in adulthood because the kidney failure becomes a problem during adulthood. Then why do we actually want to care about if the children who have ADPKD? Why do we care about the issues surrounding ADPKD at an early age? With increased monitoring, with increased ultrasound, with increased awareness, I think these children are getting diagnosed early. They can come to clinical attention because of some early clinical involvement, or if the family just chooses to screen, or if there is an incidental ultrasound detection because imaging was done for some other reason. And although the kidney cysts will keep forming throughout adulthood and will reach kidney failure later on, even early on during childhood, there can be issues with high blood pressure and protein in urine. There can be urinary tract infections, blood in urine, or any cyst infection, but mainly high blood pressure and protein in urine could be risk factors that can increase risk of progression to end-stage kidney disease later on. So this is something we want to manage early on and try to take the most benefit possible to delay the risk of kidney progression. Although screening for all children in families with ADPKD is not a definite recommendation, but it is still important to monitor for high blood pressure or protein in urine in all at-risk children. I would also like to point out an important difference between ADPKD when we see in adults versus children. In children, many non-kidney manifestations which can become a problem in adults, in children, often these are not clinical problems. For example, liver cysts are not a problem in children, and kidney failure does not happen. But again, we want to look at the risk factors like high blood pressure and large kidneys, urine tract infection, and protein in urine. Brain aneurysms are not usually a problem in children. So those non-kidney manifestations are usually not a problem in children with ADPKD. An important question which comes is should I get genetic testing for the child? It depends on every particular individual. So this needs to be discussed on an individual basis. Genetic testing in all cases of PKD is not the norm. It is a clinical diagnosis, but for the need for clinical genetic testing and also the options, how to do that genetic test, it needs to be discussed on an individual basis because there are many issues surrounding genetic testing, especially in children. And prenatal genetic diagnosis can be available on a case-to-case basis for ADPKD and ARPKD. Dr. Winklover already talked about the diet, but I would like to mention that especially in children and young adults, early lifestyle choices can have long-term impacts. These recommendations are mostly based on general recommendations for any kidney disease because we don't have very specific recommendations for PKD, but in general, restricting salt, making good hydration and healthy food choices are very important. And if these early lifestyle choices are made, they can have really long-term impacts on lifestyle in these children who are at risk for polycystic kidney disease. I would like to also mention that there are clinical trials which are mentioned on these sites, clinicaltrials.gov and clinicalstudies.pkdcure.org. And what is important in, I think, this year in 2022 is that for the first time, there are 2 tolvaptan trials now recruiting for ARPKD patients. And this is the first time that there are clinical trials actually happening in ARPKD in children. And that is, I think, a very good step in the field. I would like to conclude that PKD is really a clinically significant disorder in both children and adults, and it really needs ongoing physician-patient partnership to work towards a cure. The non-kidney associations can also be profound, and so PKD needs a multidisciplinary care. In ADPKD, we have one drug that is approved for select indications, and so hopefully there will be more in near future. And for ARPKD, there is a major advancement in 2022 with the first ever clinical trials that are recruiting. And with this, I think we can, I'll just point out that the PKD Foundation is obviously an excellent or very credible resource for all of us, for patients, families, and providers. So I encourage everybody to look at the resources, especially if somebody is looking for a PKD clinic. If there's a Find a PKD clinic option, there are handbooks for both ADPKD and ARPKD. And I think with this, we will conclude and take questions.
Okay, thank you so much, Dr. Gulati and Dr. Winkelhofer. I'm going to go to the questions and see. Oh, we have a lot of questions. Good. All right, so the first question is confirming that PKD1 is the first one expressed in the 4th or 5th decade in life.
Well, that mutation, statistically, that's true. Although the more we learn about the mutations, it kind of depends how severe the mutation involving the gene is. Does it shorten the gene, or does it just cause some misspelling? But just in general, yes, that to answer the question, PKD1 tends to be more severe and with the earlier onset.
Okay. All right. Dr. Gulati, do you want to add anything?
I would say that yes, there are what we call genotype-phenotype correlations. So depending on what kind of mutations, even within the gene PKD1, it can really, sometimes inform more as to what the age of onset. But generally, it is true that it is the 4th to 5th decade of life.
All right. Next question. What is considered high blood pressure for PKD? Is there a threshold after which people should get on medication?
I can specifically say for children and adolescents, there are blood pressure charts. There is normative data for blood pressures, and we go by something that is called centiles. And we aim for something less than 90th centile on the blood pressure, although there is data showing that aiming for even lower, much lower than the 90th centile is protective for kidney disease. But those very stringent goals are sometimes very hard to achieve clinically. So we definitely want to aim for less than 90th centiles in children based on that normative data. But in adults, there are blood pressure targets that are usually guide therapy. Dr. Winkelhofer.
Yeah, I mean, for patients that are perhaps 50 years of age and younger and have pretty preserved kidney function and less severe cystic involvement, there's a suggestion that a target of maybe 110 over 75 may be beneficial to slow progression. But as Dr. Gulati mentioned, it's sometimes pretty hard to reach that goal or reach it without significant symptoms. But the patients in that HALT trial with a lot of work were able to get down there. For patients that are older with more, that have perhaps with some progressing CKD, probably targets below 130 over 80 are reasonable.
Excellent. Next question. When one of the polycystic kidneys weren't removed after transplant, can its cyst get infected?
Yes, that can happen as well. So native nephrectomy or removal of the native kidneys is done in many cases, but not in all cases of polycystic kidney disease. And when the kidneys are still there, the cyst can still get infected, and cyst infection can be very lingering, and it can be sometimes difficult to treat, just because the medicines or the antibiotics do not get into the cyst, even when we're treating like the native kidneys. But yes, if the kidney is present, then the cyst can get infected.
I'll go to the next one. Unless Dr. Winkelhofer, do you have anything to add?
No, I thought I'll just agree.
Okay, excellent. Next question. Does dilated ascending aorta on echo increase risk of intracranial aneurysm?
No.
Yeah, I would agree. There is no data to suggest that the ascending aortic dilatation or vascular abnormality has any correlation with the intracranial aneurysm. We don't know as a community why precisely aneurysms form in PKD, but the brain aneurysm has a very strong family history component. If there is a family history, then you're at higher risk for intracranial aneurysm. But the ascending aortic aneurysm is thought to be a different form of aneurysm, which does not correlate with intracranial aneurysm, and not so much even with the family history.
Right. Next question. If you have an aneurysm and it's been stable for a couple of years, is it necessary to get a MRA each year?
We usually, if an aneurysm is discovered, then back to what Dr. Gulati said, the management of PKD often involves other specialists as well. So I kind of defer the management of that to patients would be referred to neurosurgery or perhaps interventional radiology to discuss proper screening. But generally, if there's an aneurysm there, it is something that you would continue to keep an eye on.
All right, we have 3 minutes, so I'm going to take at least 2 more questions. So the next question is, if you have an aneurysm and it's been stable for a couple of years, is it necessary to get an MRA each year? Did I read that? I'm sorry. What is, this is the question. What is the best second and third line agents for HTN?
It kind of depends. Sometimes those choices are made because of other risk factors. Patients that might have cardiovascular disease might be placed on something like a beta blocker. Patients with, or perhaps a diuretic. It really depends on the other clinical circumstances. There are a lot of different choices. So it's kind of a tough question to give a hard answer to.
And next to the last question, at what age do you recommend screening a child who has a parent with ADPKD who has not displayed any outward symptoms?
So this is, I think this question has a lot of different sides. There are no definite screening recommendations for screening a child who is in a family who has an ADPKD affected parent. There is no definite evidence-based screening recommendation. So it is mostly dependent on a couple of factors. And the most paramount is family's preference, family's choice, the parental choice. When do they want to screen? When would they like to know? The other thing is that despite whether we may or may not get imaging in a child, at least yearly with the pediatrician, a monitoring of blood pressure and urine protein is recommended, because if there is a high blood pressure, or if there is protein in urine, those could be risk factors that we can actually do something about, maybe control with lifestyle or medications, and slow the progression of kidney disease. So those two monitoring parameters are highly encouraged. If we do an ultrasound, say on a 5-year-old child, and it is negative, we absolutely cannot rule out PKD, or we are talking about the dominant form of PKD here, ADPKD, because the child can still develop kidney cysts later on. So, short of doing a genetic test, there would be no absolute way to rule out by ultrasound in a small child as to what the risk for ADPKD is. And genetic testing in children have, many ethical, legal, social issues, which again need a discussion on an individual basis. But I would say that as long as the family is doing blood pressure and protein monitoring with the pediatrician, it is certainly their choice to discuss with their pediatrician as to whether they want to do an ultrasound. And if the ultrasound is done and we find something, then a referral to a nephrologist.